Good afternoon, everyone. Welcome to the University of Alberta Division of Gastroenterology IBD webcast. I'm Dr. Richard Fedorik, and beside me here is Dr. Leo Dielman, and special guest Dr. Karen Croker will be joining us later in the show. This is the second in our IBD webcasts going across Canada. Last month, we had the opportunity to talk to you in our first webcast about inflammatory bowel disease 101. We gave you some oversight. And today, we're fortunate enough to be talking to you about inflammatory bowel disease, making the diagnosis. This webcast is divided into two sections. The first half hour will be aimed at patients. And at the half hour, we'll switch over to speaking directly to physicians. And during that time, the patients, of course, are welcome to continue to listen in. So in this first part of the session, I want to begin by discussing with you a number of points relative to making the diagnosis of IBD, and then we'll have an opportunity for you to ask questions of Dr. Dielman and myself, and when Dr. Croker joins us, of Dr. Croker. So let's begin. I'll have the slides queued up. I have a couple of slides that I want to show to you, talk to you about, and then we can begin with your questions. So on this slide here, I placed a diagram. There's two diagrams of the large intestine and then a diagram of the large intestine with a small amount of small intestine there. You'll see that doctors think of inflammatory bowel disease as two diseases. One, on the left-hand side, is ulcerative colitis. Ulcerative colitis is an inflammation of the large intestine. What that means is that the large intestine is lined with something like your skin. In ulcerative colitis, that lining wears away, leading to pain, cramps, and diarrhea. Now, Crohn's disease, the diagram on the right, is a little different. It can also involve the large intestine. You see that indicated there by the red areas on the diagram. But you'll also see that it can involve the small intestine, indicated by that red area in the small intestine. So the differences for us in making the diagnosis is, does the patient have ulcerative colitis, where the inflammation only involves the large intestine, or does the patient have Crohn's disease, where the inflammation involves both the large intestine and the small intestine? So that's where we begin. Next. Now, symptoms are different. When you come to us as a patient with symptoms of inflammatory bowel disease, we're looking for a couple of really important items. We're going to ask you if you have diarrhea. Fair enough. Patients with ulcerative colitis tend to have diarrhea with blood. In contrast, patients with Crohn's disease, while they may have diarrhea, don't tend to have much blood. So for us, that's a distinguishing feature. Patients with ulcerative colitis have pain and cramps. And you'll notice that patients with Crohn's disease also have pain and cramps. So that's not great distinguishing feature. Patients with Crohn's disease have weight loss. Now that's a distinguishing feature because patients with ulcerative colitis don't. So your doctor will ask you these questions in many different ways and at different times in your history taking in order to determine whether your history is more like ulcerative colitis or more like Crohn's disease. Next. So what might you expect? You are going to the doctor, you're worried that you may have inflammatory bowel disease. Your doctor is going to do a number of things in making the diagnosis for you. As we've just talked about, there's going to be a detailed history and physical examination. Your doctor is going to want to try by your symptoms to determine whether this is ulcerative colitis or Crohn's disease, or maybe even something else. There are other things that can mimic inflammatory bowel disease. As Dr. Dielman knows, an infection of the intestine can sometimes mimic that disease. Something called Irritable bowel syndrome, which is completely different, can mimic some of the symptoms. So your doctor is going to take the history and physical and try and sort that through. He or she will probably send you for some blood tests. And once that's completed, you'll probably go back for a second visit. And your doctor will then try to determine whether, based on the history, physical, and blood test, it looks like you have inflammatory bowel disease. And if that's true, you may at this point be sent on to a specialist, or your family practitioner or internist may do some other tests. What are those other tests? Well, something called a CT scan, a CAT scan. That's a computerized X-ray of the intestine. You'll be asked to drink some fluid. You'll be asked to lay on an X-ray machine, and you'll get these X-rays taken, which will help determine if there's inflammation in the body, if there's inflammation in the lining of that intestine. Sometimes, in addition to the CAT scan, or in place of the CAT scan, your doctor will choose to do an MRI. That's a short form for a magnetic resonance imaging technique. And it will give similar pictures to the CAT scan, also looking for inflammation in the lining of the intestine. And those are two very new but very excellent tests to make this diagnosis. Once that's completed, your doctor will also probably at this point send you to a surgeon or a gastroenterologist, and you'll undergo a gastroscopy, which is a video camera down through your swallowing pipe into your stomach, and a colonoscopy, where a different video camera is put up into the large intestine. It allows your doctors to take pictures of the inflammatory bowel disease, to get biopsies, to get all the information they need from these tests, the history, the physical, the blood tests, the X-rays, now the endoscopies, to be able to determine the extent, severity of your disease, where it is, and how they might best treat it. Okay, so I've told you some of the individual components. Let's go on to the next part. Now this is a little, I call it a bubble diagram, but you'll see that making the diagnosis of inflammatory bowel disease in you or your family or your friends does not fall under a single individual test. There is no single blood test, there's no single piece of history, no single X-ray that tells us you have inflammatory bowel disease. You require to have many different things that your doctor puts together to make that diagnosis. So up on the screen you should see 4 green balls and 1 big blue ball. The blue ball is inflammatory bowel disease. The green ball are the symptoms, which come from your history, the physical exam, which comes from when you see your doctor, the various blood tests, and then a combination of the X-rays and endoscopy. And only when all of these are completed does your doctor make that diagnosis of either ulcerative colitis, affecting the large intestine only, or Crohn's disease, which affects both large and small intestine. So I've given you an overview in 5 or 6 minutes of the diagnosis of inflammatory bowel disease. So now I'm going to pause for a bit and I'm going to turn it to you, and you'll have an opportunity to give us your questions, which Dr. Dielman and I will try and answer related to the diagnosis of inflammatory bowel disease. So any questions that you may have, type them in now and we'll be able to see them and be able to answer them for you. So I'm going to ask Dr. Dielman maybe the first question, which is a common one, and that is people are often having symptoms that sound like inflammatory bowel disease, but they get told it's irritable bowel. Are those two things the same?
Right. Well, they're actually the main difference between irritable bowel syndrome and IBD or ulcerative colitis and Crohn's disease, as you remember, these are the 2 diseases we're looking at, is that that irritable bowel disease is a functional disorder. That means if you look into the intestines or you take an X-ray, there is absolutely no abnormality at all. There is no visible inflammation. And I think, and the treatment for that is also different, because one is an inflammation, such as Crohn's disease and ulcerative colitis, versus irritable bowel doesn't have inflammation and typically does not get treated with anti-inflammatory medication. So that is quite important. And there's lots of people, they say, yeah, I think I heard that my grandmother had colitis. And sometimes it gets really confused with IBS. And what they mean by colitis actually means that it is irritable bowel syndrome.
Right. And so we have to sort out that irritable bowel versus inflammatory bowel, and your doctor can do that in getting to that diagnosis.
Right, yeah.
We've got many questions coming up, and so let's go to another question. I'm not sure where this question came from, what part of Canada it's from, but it says, can a person have completely normal tests that we've just described and have inflammatory bowel disease? Does that happen very often?
Well, it's one of the things that we actually screen. If we get to these referrals from your physician, and they give you the lab test, and sometimes there is already some endoscopy done, and just say that this is done by a person that you trust, that knows what he's doing. If you say normal endoscopy, you'll have to ask, like, okay, what does this endoscopy mean? Does it mean a sigmoidoscopy or is it a full colonoscopy? Because sometimes your disease may be in the right colon versus in the left colon. And this, if for instance your surgeon has done an investigation and only looked at the left colon but missed the right one, well, that could still be disease. And then the other thing is,
the quality of the tests.
The quality tests are really important. Yeah. So, and that brings up another point, is that some people get sometimes frustrated with us that we start redoing some of these tests.
Right.
So I don't know how you do that, but
yeah, it's true. You need to make sure that the tests are quality, and sometimes you have to repeat them because there's your body's change, and what may not have been there before is now visible as colitis.
Right, right. So
reasonable.
Also depends how long ago this was done, right? Yeah.
So we're fortunate to have Dr. Karen Croker join us. She was tied up in the emergency room, but we're glad that you're here. Welcome, Karen, to the program.
Sorry I'm late.
So maybe, Karen, I'll ask you one of the questions here. The question is, how do you differentiate infectious colitis from inflammatory bowel disease?
Okay, that's a good question. So first of all, infectious colitis is usually something that is short-lived, and usually there's some sort of infectious agent, although we're not always able to identify it. So the first thing we usually do is check your stools for things like ova and parasites, which come from parasitic type infections, or we check for what's called culture insensitivity, that is looking for kind of bacteria that can cause infectious colitis. The thing about it is if you have inflammatory bowel disease, you can also get infectious colitis. And so it doesn't necessarily mean you have to have one or the other. But if you have infectious colitis, it usually is short-lived and often is self-limited, whereas IBD is a chronic, lifelong condition.
Right. So infectious colitis usually is a couple of weeks, couple of days. It's not, doesn't last for months.
Shouldn't last forever, no.
Right. Good point. So I'm going to give you also the next question, because Dr. Dielman and I have been working quite hard here, and you've just arrived. Which is a question we get asked a lot. So I have Crohn's colitis. Do I have Crohn's or colitis?
We have both. So the difference is that colitis just refers to an anatomical distribution. So your intestine is divided into your esophagus is your swallowing tube, your stomach, then your small intestine, and your colon. And so your colon is like the large intestine. And so if you have inflammation in your colon, it's called colitis. And colitis can be many things. So you can have inflammatory bowel disease, and you can have Crohn's colitis, or you can have ulcerative colitis, or something called indeterminate colitis when we're just not smart enough to figure it out. Or you can have other things like infectious colitis, because that affects your colon, or you can have ischemic colitis. So colitis just is anatomical, whereas Crohn's is a pathological diagnosis. So
you want to have your doctor distinguish whether you have Crohn's colitis or ulcerative colitis. Mm-hmm. That's the important distinguishing feature here.
Yep.
Good. Another good question coming up here. My daughter has had multiple tests and was told she had irritable bowel syndrome. Leo, you've talked about that already. But she continues to lose weight, has pain, and now actually has some bleeding. Could it be possible, Dr. Dielman, that what started out as irritable bowel symptoms has now developed into inflammatory bowel disease.
Yeah, so that's one of those questions like, how much time do I have to talk about this?
You only have a short
But you know, there is how to say, is a continuum between irritable bowel syndrome and these diseases. It's not to say that once you have been diagnosed with irritable bowel syndrome, you always have irritable bowel syndrome. We know that there are some people, and I've had them a few in my own practice, that who are going from IBS into a chronic inflammation such as ulcerative colitis or Crohn's disease. So bleeding is not a symptom of irritable bowel syndrome. If that's the case, you ought to have a peak, and this means typically doing a colonoscopy.
Right.
And blood work.
And blood work. And so the question here is like, should we ask for further tests for IBD? Yes, you need to do your we call this routine blood work. It's like inflammatory markers in your blood. You can have some for instance, your white cell count can be up, your sedimentation rate can be up. Those are all signs of inflammation. If those are up that weren't up before, well, you know, that's actually an alarm symptom. They have the bleeding. The bleeding is an alarm symptom,
the weight loss.
and then the weight loss, and then you have further tests that are indicating that now something is different. Yeah. So yeah, it can change.
Okay, excellent.
Yeah.
So another question, Dr. Croker. If we use colonoscopy and gastroscopy to make the diagnosis, why don't we do that on everybody? Why isn't that the first test?
I don't understand the question. Why do we not just go, everyone get a colonoscopy?
Yeah.
Oh, because I think what it is that a colonoscopy is part of the diagnostic test, but it also, you have to have the clinical picture to convince us that this is important in our differential. So every test that we do has risks and benefits, and there are risks of doing a colonoscopy, and so if we don't think it's indicated, then we shouldn't take the risk, because you should always have a benefit to outweigh the risk of the test.
That's why we start with the history and the physical and some blood tests and then move forward.
So there's very little risk to history.
Right. But I think, let me add to that, there's sometimes you have this so-called uncertainty, and you're not really sure what has been seen, if that you can really trust it, or has that been some time ago, patient comes with a diagnosis from so-called ulcerative colitis, and you have never seen that patient. Sometimes I do a full colonoscopy, right?
Doing a scope, especially with biopsies to look for underlying changes and stuff, can be really helpful. But it's helpful to have that history because it can make it easier for us to do our job. But at the same time, without it, sometimes if we're not sure, we have to check again.
So another question about gastroscopy. So we've talked about, and you missed this part, Dr. Croker, but we're talking about ulcerative colitis and Crohn's colitis and Crohn's disease and showing pictures of the colon. But why would you do a gastroscopy, which is looking at the stomach, if you're worried about IBD? Why would you ever do that?
Well, because Crohn's disease can affect you anywhere from your gums to your bum, and so we don't see, with the colonoscopy, we only see your large intestine, and maybe the last part of your small intestine called your terminal ileum. So when you have, especially when you have symptoms of nausea and abdominal stomach pains, it makes us think that you might have Crohn's in your stomach, your esophagus, or your first part of your small intestine. But the thing about it is even with both of those tests, sometimes it's not enough because people can have, because it can affect anywhere along your small intestine, we can't see the middle part of your small bowel. And sometimes we have to do special tests like a CT test called a CT enterography or an MR enterography. And sometimes we do a capsule test where you swallow a camera. And so there's lots of different ways that we look at it, but those two tests alone aren't always enough to distinguish, to tell you don't have Crohn's disease. Good. So some people will need a gastroscopy in their diagnosis workup. Good. And you only have to fast for it, so it's not a bad test. This next question is somebody who's obviously been doing some reading, and they're talking about a new stool test. And I think, Dr. Dielman, they're probably talking about fecal calprotectin.
Yeah, exactly, yeah.
And the question is, can this new stool test help diagnose IBD?
So that is a really good question. The new stool test, what it really does is, it is called fecal calprotectin, and what it really refers to, that they can pick up so-called inflammatory markers in your stool. Now, if they are elevated, that means that you likely have inflammation. But that being said, it also means that inflammation, as you already heard before, can come from very different sources. It can come from Crohn's disease, it can come from ulcerative colitis, but can also come from like infectious colitis. So the fact that your stool test is elevated really doesn't mean that you can say, now I have IBD. So, and then the next question is like, can it replace colonoscopy? Not if you have not been diagnosed with this before. I would do a diagnosis for colonoscopy. Now, that also means if you're known with the disease and you're all of a sudden your marker is elevated and maybe you already have some symptoms, that's even a reason to have a look.
So it's kind of like a bit of, the analogy would be a blood test. It helps in making the diagnosis, but it doesn't absolutely make it
better than the blood test because it tells you that there is something wrong in your intestine.
But you don't know what that wrong is yet, right? Whether it's inflammation, whether it's infection.
But then also comes the other point. If you do the blood test and you have only the blood test, and you are for instance, you have an elevated sedimentation rate, that means that there is an inflammation somewhere in your body, and it can also you have a common cold.
Right.
Yeah.
So let's move on to some other questions. There's lots of them here. I have a diagnosis of ulcerative colitis, but my gastroenterologist said because I have fissure and fistulas that he thinks I have Crohn's disease. Dr. Croker, what does he mean?
So did you guys describe what a fistula and a fissure are?
We didn't actually, so that's a good opportunity for you to do that.
So first of all, a fissure is usually, it's almost like a cut along your anus. So it's usually painful, and you could get this from chronic constipation, but you can also get it with Crohn's disease. And a fistula is when there's a kind of an ulcer in your bowel and it makes a tract such that you have an opening of like kind of a hole around your bottom end, and that actually can drain pus and stool and things like that. And so usually if you have a fistula or fissure, we do think you're more likely to have Crohn's than ulcerative colitis, because ulcerative colitis is supposed to be a mucosal disease, just confined to the inner surface lining of the bowel, whereas Crohn's disease goes right through the bowel. And so in order to develop a fistula, you actually usually have to have an ulcer developing through the wall of the bowel in order for you to get that fistula. So I think it's worth considering, and I actually would probably think you had Crohn's too.
So probably more likely they have Crohn's, but we have seen fissures and fistulas in ulcerative colitis.
Well, normal people that don't have any bowel disease can get a fistula or fissure as well. Right. And so that was probably the same mechanism by which people with ulcerative colitis would develop these.
Which brings me to the point, does it really make a difference? Because, Dr. Dielman, do we use the same drugs?
If you're having a fistula, like say if you have Crohn's disease,
for Crohn's and ulcerative colitis, do we use the same drugs?
Well, not really. I mean, we know that, for instance, for ulcerative colitis, the drugs that we call the 5-ASA drugs, and we'll talk about in one of the other sessions.
Yes, that's right.
So, but those are the first line treatments that we give a patient with ulcerative colitis. Those are like you probably remember, Asacol, Salifalc, Pentasa, and those drugs. They're typically working really, really well for ulcerative colitis. When you have active Crohn's disease, they really don't work that well. There are exceptions though. Very mild Crohn's disease can be treated with that. And I think for Crohn's disease, we also will use more frequently, or more early, I should say, immunosuppressors. Mm-hmm. So there is definitely a treatment difference.
So the drugs might be somewhat similar in both diseases, but we use them in different doses.
If you look at like what drugs we have, then
don't give away the next.
No,
session.
I will not give away, but I will tell you a little secret. That's something to do with the triangle.
Okay, the pyramid of treatment. Yeah.
But what about surgery? Does it change what you're going to do surgery-wise?
And that's an excellent point, as people really need to know why we want to know. So once your disease has progressed that you need to have your colon removed, for instance, like an ulcerative colitis, or in a severe Crohn's colitis, you're going to also have to have your colon removed. That's really important to know, because once you have your colon removed, the surgeon is going to ask, okay, now what? Do you want to have a temporary bag, and you make a connection between the small bowel and the anus, a kind of reservoir, we call it a pouch. That works really well with ulcerative colitis. But if you have Crohn's disease, mm-hmm. and particularly when you get Crohn's disease in that small bowel that they're going to have to use for surgery, then there's a chance that you have recurrent disease, that you can have leakage, and surgeon and the patient will not be happy with that approach.
So being clear, ulcerative colitis versus Crohn's is really important in surgical planning.
Right, that's right.
So I'm going to pause here for a minute. We have some time, and we have many questions coming. But I want, this is an advertisement, I want to tell you that this information will be on our IBD website, www.ibdclinic.ca, so you can see this webcast, you can see the one we did last month, and all the subsequent 12 webcasts that are coming up through 2013. It's also important that you know that the production for this webcast is made possible in part by unrestricted educational grant from AbbVie Canada. So that's important that you know that they're supporting that, and Teachers Media, who is running the production here. So we have some more questions coming, and let me go through this one. It's a long question, but I'll read it to the audience. It says, speaking of surgery, I knew someone who had ulcerative colitis and had their colon removed. So as Dr. Dielman was talking about, the surgery for colitis. But now they're having problems and lots of diarrhea. And now their doctors are saying they didn't have ulcerative colitis, but they actually had Crohn's disease. How can this happen? So maybe Dr. Croker, do you want to take this one?
Can this be? Well, I think it's a difficult question because it's true, sometimes it's hard to tell Crohn's disease and ulcerative colitis. I think that sometimes people have disease that overlaps, and so you might have had ulcerative colitis, but now you've developed into Crohn's because there's several genes that are involved in the disease, and they can be involved in both Crohn's and ulcerative colitis. And so it might very well have been that you had ulcerative colitis and now have Crohn's, but you might have always had Crohn's all along, and we just weren't smart enough to figure it out. So the problem is that once you have diarrhea, it sounds like if they've had a colectomy, they might also have a pouch. So then if they have a pouch, they might develop something like pouchitis or inflammation of this pouch, or they could actually have developed Crohn's. But it is an important distinction because pouchitis usually responds pretty quickly to antibiotics, whereas Crohn's disease usually you have to treat with our Crohn's medications. And so sometimes it's hard because patients chose to have a colectomy to avoid medicines, and then now I would want to give them medicines again. So I think that's always something that we keep in mind. And so especially when people are younger, when they have their colectomy, the ability for us to distinguish is harder than later on in life where people's disease are a little bit more distinct.
Right.
So Dr. Dielman, we're making this diagnosis now. What's the age group that we think where IBD comes on?
Well, IBD is typically a disease where we call it for the adolescents, for the younger people. It is, I'm talking about people in their 20s, 30s. But we also begin to see IBD and ask the pediatrics colleagues to see lots of children now, and more. It's actually quite remarkable how quickly and how more we see these diseases happening in children. I remember doing a research rotation in Alabama. This was like in the 1980s, where pediatrics were not.
That's a long time ago,
Dr. Dielman.
Yeah, that's how old we all are, right?
So
I hear this all the time at home.
So basically, you're telling us that the diagnosis of IBD is often made in the young people, not people who are 70 or 80 years old.
Right, but there are exceptions, though. There are people that can actually have these diseases when they're older, and we begin to recognize.
But the majority are in their
majority, like taking
15 to 25 age group.
Very typical. Yeah.
Okay.
Yeah.
We've got about 2 or 3 more minutes for the patient section of this webcast, and then we're actually going to move on to the physician section, where we'll have a short presentation by Dr. Croker and Dr. Dielman, and then answer questions from the physicians across Alberta and Canada. But we have time for a few more patient questions. And this one is asking... It's a complex one. It says, can you go through the non-intestinal symptoms of IBD? And Dr. Croker, we didn't talk about those, but can you list some of the common ones? We call them extraintestinal manifestations, Dr. Croker, of inflammatory bowel disease.
Just help me out, just so I know what they are. That's excellent, Dr. Fedoruk. So I guess the first things that we often talk about, so often we look at things of mouth ulcers. And so mouth ulcers, anyone can get mouth ulcers, but it is one of the signs of Crohn's disease.
Like canker sores.
Canker sores. And so not usually cold sores that you get outside your mouth, but canker sores that you get inside your mouth. And we call these aphthous ulcers. And that's often what the ulcers look like in your bowel when we scope, is look like almost like a canker sore. The next thing is that you can get a number of eye symptoms. And so eye symptoms that you can get are often red, painful eyes. And so usually anyone can get red eye because they're a little bit dry and things like this. And we learned a lot about dry eye at one of our meetings recently. But it's usually something called uveitis or episcleritis, some sort of inflammation of the eye. And then the next kind of symptoms you can get are some rashes. And so probably we should have pictures of these rashes, but there's two main rashes that we see. And one is called erythema nodosum. And it kind of looks like a bruise. Usually you get it on the shins of your legs. And it actually, but it's raised. So it's called nodosum because there's a bump to it. So if you put your finger over it, you should feel a bump, whereas most bruises are quite flat. And another thing is something called pyoderma gangrenosum. And so pyoderma gangrenosum you wouldn't ignore because it's kind of like a deep ulcer in your leg, and so you should never have a deep ulcer in your leg. So if you see these things, and actually if our colleagues see, especially pyoderma gangrenosum, they always want to know if they might have Crohn's
And the joints,
disease.
you get arthritis?
Oh yes, I forgot about the joints. So yes, you can get joint symptoms that relate, and sometimes your joint symptoms get worse when your bowel is worse, and sometimes they're not really related. But usually when we treat your bowel disease, your joints get better.
And so one of the last patient questions then, do you ever see those extraintestinal manifestations with irritable bowel?
Well, there's other reasons you can get these rashes, or you can get these eye symptoms, or you can, but it's always worthwhile for us. It's probably enough for us to investigate doing gastroscopy and colonoscopy to look for IBD if you have these symptoms. But I can't say that doctors never say always or never say never.
But they generally make you would think of inflammatory bowel disease.
Oh yeah,
absolutely. Good. All right. Well, listen. Thank you, everyone. I know there's still questions out there that we haven't been able to answer, but we're at the half hour, and we want to move on to the physician part of this webcast. And patients, you're welcome to stay. Doctors who are joining us now, thank you very much, and welcome to our webcasting. For the physicians, again, this is number 2 in a series through 2013. There'll be 12 webcasts. This one is on making the diagnosis of IBD, and it's number 2 in our series. You can see all of the webcasts at www.ibdclinic.ca. So let's begin, and we'll have Dr. Dielman. We have really 6 slides we want to show the physicians and talk about and teach around, and we'll have Dr. Dielman do the first 3, and then Dr. Croker can finish up with the last 3. So
you know.
Just because I'm late.
It's because he's older.
Oh, gee.
Thank you.
Okay, so thank you for joining us, and we just want to give a little overview for the physician. So what kind of symptoms make you suspicious that your patient actually might have Crohn's disease or ulcerative colitis? And the first thing, so we will do it in different sections. We'll have symptoms, as we know, by history, symptoms as you come by physical exam, blood test, or maybe some of the diagnostic tests. So the first one is your patient comes to you with complaints and symptoms. And so we just talked about that the onset for these diseases is typical in patients that are younger than 20s and their 30s. But you have to remember that these diseases can actually be diagnosed at any age, and we have recently also seen some patients that are older, that are actually sometimes even in their 70s or 60s, and we also have the disease now diagnosed more frequently in children. Now, what kind of symptoms are we typically looking for? Well, somebody who comes with diarrhea is a very asymptomatic symptom. It can be seen in IBS, it can be seen in infectious disease, it can be seen in Crohn's and ulcerative colitis. However, when the symptom goes together with blood loss, like you have bloody diarrhea, that is an indication that, particularly if it's a long-standing symptom, not just like, oh, I went to Mexico and I came with an infection, but it's a so-called non-self-limiting disease that you have to be suspicious for. This patient could suffer, for instance, from ulcerative colitis or from Crohn's colitis. The other symptom that we need to look for, which we call another alarm symptom, is weight loss. And weight loss can be seen especially in conjunction with a patient with Crohn's disease. Now, the other question you want to ask the patient, if the patient has a family history of IBD. And that by itself is not always helpful, but if you have a positive family history, that would make you more suspicious that the patient actually has IBD. Now, that being said, family history is more frequently seen in patients with Crohn's disease than in ulcerative colitis, so the genetic component of that can be a little different in the way that it will penetrate, and or other environmental factors can play a role as well. Now, the other things that you want to look for, and then you already start to get into the lab testing, if the patient has iron deficiency. So a patient with iron deficiency not caused by menstrual blood loss is typical, and you suspect the GI source together with these other symptoms such as bloody diarrhea, weight loss, or diarrhea in general, makes you suspicious that the patient may actually have IBD. Now, that being said, we already talked about, for instance, the diarrhea. And once you have the diarrhea, like you do typically with all the patients that you see, you want to know something about frequency. So how frequent are these bowel movements? Are they 3 or 4 times a day, or we talk about 20 bowel movements a day? And that makes this is important for our referrals, because somebody who has 20 bowel movements a day, particularly with blood, needs to be seen a lot sooner than somebody who has 1 to 2 bowel movements that are a little bit on the loose side. And you can want to ask if the bowel movements are nocturnal, because that's actually quite an inconvenient symptom for patients. The urgency is frequently seen in patients who have inflammation in their very distal part of the intestine, very distal part of the colon, and can be responsible for lots of bowel movements and inconveniences. And some people actually are incontinent, particularly already when you have something like not such a strong sphincter. The other symptoms is abdominal pain, so you have cramping, and this is a very asymptomatic symptom seen with IBS patients as well as IBD, and pain with eating. If you take a good history and the pain is associated with eating, that could mean that you're, depending on the time relation between the pain and the eating, are we looking at some upper GI manifestations? And we know that upper GI manifestations can play a role in Crohn's disease. But it could also be very asymptomatic, that the patient might have an ulcer because of the NSAIDs that the patient is using, or if it's a little bit later in the meal, a patient has cramping 30 minutes to an hour, you got to think about, may the patient have an obstruction. Weight loss is, you need to say, in weight loss, you need to quantify it. I mean, are we talking about a few pounds? Or are we talking about a significant weight loss? And significant weight loss is an alarm symptom that needs to be especially looked at, and also will make the urgency of that referral a bit more urgent. Now, Dr. Croker just talked about some of the extraintestinal manifestations that you look for, and to just to reiterate that particular symptoms, you can actually have mouth ulcerations. You can see that both in ulcerative colitis and Crohn's disease. You can actually have skin manifestation called erythema nodosum, typically found in the lower part of the extremities, and pyoderma gangrenosum, little vesicles, bluish kind of, that can be quite deep at some points, typically at area of previous abrasions or previous surgery, but also somewhere else, and can pop up in the extremities. You can actually have pain in the joints, what we call arthralgias, or you can even have arthritis, which means that you have a swelling inside the joint that can go up and down with the disease, but not always. Now, lastly, we have symptoms that are eye manifestations. You can have uveitis, which is an important thing to diagnose, because with uveitis you can actually have vision loss, and the patient needs to be seen by an ophthalmologist as soon as possible, and as well as episcleritis. Those are the extraintestinal manifestations of the disease that are being seen. So on physical exam, so what do you look for? Generally, you look for what you normally do. You measure the weight and the height, particularly for a patient with weight loss. It's important. If the patient is anemic, is it something that strikes you? And then in the abdominal part, you look at abdominal tenderness, and particularly important, and that's very true for Crohn's disease, you can have a so-called infiltrate around the inflamed part of the colon or the intestine, the small intestine. We call this a mass. So a patient comes to you with these symptoms, and you palpate an abdominal mass. And this is a young patient, and the patient has already, for instance, like fever, then it indicates that there's definitely an alarm symptom that this patient needs to be looked at soon. Then don't forget to do a anal inspection. It's a lot of times that people don't do it enough, and during an anal inspection, you really find out little things like there could be a small fistula opening that the patient may have maybe not noticed or not ever told you about, because nobody wants to talk about fecal incontinence, nobody wants to talk about stuff, but sometimes you really have to ask for it. Like if you notice that stool is coming out in openings somewhere else than the anus or in your skin, and people sometimes are too shy to talk about these really, really debilitating symptoms. And the fissures that can be seen in both diseases, but also people that don't have IBD, and that means that your people, and particularly somebody who has painful defecation, so look for that. Now, the extraintestinal manifestation we just talked about, so you ask for them and then you look for them by looks, and a careful mouth inspection really belongs to your one of the things to do in physical exam on a patient that you suspect to have IBD. And the eye manifestations, I mean, we always, not routinely, but in a patient who is suspicious for that, particularly a patient who complains about a red eye or loss of vision, is just to do a quick inspection of the eye. Actually belongs to the armamentarium that you need to look for. And the skin and the joints the same way. So. Okay,
well, thank you, Dr. Dielman, who's covered the history and physical, some of the salient points that we're hoping the physicians will be able to complete. And now move on, have Dr. Croker talk a little bit about the investigations and then what we, as gastroenterologists, would like to see in a patient being referred to us. So, okay. Dr. Croker?
Sure. So I guess it's kind of like our medical student history. We take the history, we examine the patient, then we want to do our investigations. So if you may have known, the way we practice is we almost always get people to have blood work before they come to see us, but that's one of the things that helps us triage referrals. So the first thing I always do is a CBC, because you want to look for evidence of anemia, of white blood cell count, or even elevated platelets, which is kind of what I would call the poor man's CRP. So elevated platelets can be a sign of inflammation, and so if they're going up, even if you don't have a CRP, that's a marker of inflammation. Then we always look at electrolytes and creatinine, mostly to look to see if there's any significant problems with diarrhea, but also because we often want to know if the creatinine's normal in terms of medications that we use, especially the 5-ASA products. And so it's always important for us to check that out before. Iron studies are important for us, not only in people that have a microcytic picture, but also with any patient we're looking for iron deficiency, because we know that's common in patients with both Crohn's and ulcerative colitis. Inflammatory markers, getting a CRP or ESR. We tend to use CRP more than ESR in IBD, although I know the rheumatology people use ESR more. But some people don't make a CRP. I'm not fully sure I understand why, but they might make an ESR. Albumin is a good test to look for how much nutritional status. So if your albumin's really low, it can either be because you have severe colitis, ulcerative colitis, and you're losing albumin in your colon, or it could be just malnutrition from Crohn's disease because you've been sick for quite a while. And so many times we'll get patients referred to us and their albumin can be like 22, and those kind of things actually help us in terms of triaging and seeing how sick they are, because an albumin of 22 is not usually a good thing. We also look for other nutritional things like B12 and folate. And so B12 is really important because we know that the final absorption of the pathway is in your terminal ileum. So people with Crohn's disease or people with previous resections often can't absorb B12, and so it might be low. Because we're always looking for infection in people with, especially with diarrhea symptoms, it's actually really helpful if we can check for infectious things. So a history of antibiotic use is good, and even to do the C. diff toxin to make sure they don't have C. difficile. We also look for other infectious things like the CNS and ONP, and sometimes the history can be helpful, but sometimes it's not that easy to obtain. The next thing that we would do is usually, and maybe there's some people that have, I'm not sure if there's some people that work more in the rural communities that might actually be doing endoscopy for patients. And so usually colonoscopy is the first test to look for people with diarrhea and suspected IBD. If you do think that they have Crohn's, looking in the stomach as well is also important. And so the big thing for us is that we always want to, if you do endoscopy, there's the first thing is you want to know what it looks like, but you also want to know the extent of it. So if you have ulcerative colitis, does it just affect your rectum? Does it go all the way around to your cecum? Where does it end? And so it's one thing we do is look endoscopically, but also take biopsies to look for that. For Crohn's disease, it's always important to try to look in the terminal ileum because probably 2/3 of patients with IBD actually have ileal disease. So it's the money shot. Next, in terms of your symptoms, Dr. Dealman said you remember to examine the abdomen for masses. And so if you feel a mass, an ultrasound is a good first test to do to see whether or not this is an abscess or not, because that's the one thing that we worry about, especially in suspected Crohn's disease, is that if an ulcer goes right through the bowel wall and they actually can develop an abscess or a collection of pus, we would want to treat that sooner, and sometimes you need to either drain it with radiology or surgically. And so that's a more significant thing than if they just have an inflammatory masses, which would probably more common to see. And then earlier we talked a bit about when we can't see the small intestine, doing a CT enterography or an MR enterography is actually really important for staging people with small bowel Crohn's disease. And so for most people that we think have Crohn's disease, we actually would order this at some point. So CT enterography, we always worry a little bit about CTs, especially in these young patients in terms of their radiation exposure. And so when people are really young, especially in pediatrics, we would order an MR enterography, which doesn't give you quite as good a pictures, but it doesn't expose them to any radiation, and so it's generally a preferred test. If you examine the patient and you feel a fluctuant mass or you think they have perianal disease, an MRI of their pelvis is also really important for delineating perianal disease, and it can also be helpful in determining which type of treatment we're going to use. Can I have the next slide? So then I guess what we wanted to do is kind of distinguish Crohn's and colitis in terms of a chart, and I see Dr. Fedoruk has taken out my one thing because there's an empty box at the bottom. So first of all, Crohn's disease presents quite differently. So you can get diarrhea with Crohn's, but usually it's non-bloody, although it can be bloody. But usually it's non-bloody. Pain is more particular for Crohn's disease in that, especially if you have small bowel disease. So if you have an inflamed small intestine, as peristalsis moves through, and actually stool contents can get caught up there, and that can cause abdominal pain. So sometimes people have multiple lesions, like skip lesions, which is classic for Crohn's. And so sometimes it just can't get through, finally gets through, their pain relieves, and it tries to go through the next stricture. And so patients can often describe this type of pain and bloating and things like that they get it. And it's often quite different than the bloating people get with IBS when they tell you you're 7 months pregnant. Weight loss is always worrisome because, as you know, the weight loss industry is $1 billion-some industry. Nobody can lose weight in our culture. So if people are losing weight without any difficulty, it's a bit of a sign that there's something wrong with you because the rest of us can't lose weight. Iron deficiency. So we see that in both diseases, but iron deficiency without overt bleeding is actually more of a sign for Crohn's. And obviously perianal disease, the fistulas and fissures are more likely in Crohn's. Ulcerative colitis almost always presents with bloody diarrhea. If you have mild ulcerative colitis, it's possible you can have diarrhea without blood that they can see, but usually they will be iron deficient. They'll get more of the cramping. They get the tenesmus where they can't, the feeling of incomplete evacuation, and the urgency and incontinence is much more common in ulcerative colitis because Crohn's colitis is usually rectal sparing, or at least relative rectal sparing, and so it's less likely to lead to so much urgency. Endoscopically, we can look, and ulcerative colitis is just usually superficial, and you can see pseudopolyps, which sometimes people take off and you wonder, does this like an adenomatous polyp? But usually you can tell the difference, and they can tell definitely under the microscope. And in Crohn's disease, there's often these linear serpiginous ulcers, and so they're deep, and they can start just like an aphthous ulcer in your mouth, but then they can develop in these deep serpiginous ulcers. Usually there's skip lesions. That's the hallmark for Crohn's disease, is that you'll start scoping, you'll see an area of inflammation, you'll keep moving, and all of a sudden they have perfectly normal bowel. and then you get to another area, and then it's diseased again. And it's so much in keeping with Crohn's disease. And then there's sometimes cobblestoning. You can get this appearance of almost like cobblestones, like the streets, but it's hard sometimes to distinguish this from pseudopolyps. The distribution, the skip lesions, and remember it can affect anywhere from your gums to your bum. And ulcerative colitis, it starts in the rectum, and it's contiguous, and it affects the colon only. There are some cases where it can actually, you can have a little bit of your ileum, what do you call that?
Backwash
ileitis,
yes.
But you can usually distinguish this. On pathology, we can see transmural inflammation, but that's usually more likely to be seen on a pathology specimen than actually a biopsy. Seeing granulomas is actually more specific for Crohn's disease, the skip lesions. If you have strictures, and then on a pathology specimen, you can see creeping fat. In ulcerative colitis, the inflammation is just confined to the mucosa, and they often describe crypt abscesses. So whenever we look at the biopsy reports of patients with a relatively acute colitis, and we're trying to distinguish if this is infectious colitis or ulcerative colitis, we look for what they say signs of chronicity, because ulcerative colitis is a chronic disease, not an acute disease. And lastly, I guess what we wanted to talk about was what kind of information do we require for a referral. So the first thing, and I think our referral sheet's on our website, and we want to know, is this known IBD and you want us to see them, or is this just suspected IBD? And if it's known, I guess we want to know how you know this, because people often, they're young people that get this disease and they move from province to province and place to place, and so they might be looking for a new doctor because they've moved to town and they know they have IBD, and then all of a sudden they're sick. And so that kind of thing, that past history stuff is really important, especially if they've had surgeries, and some of those surgical reports, especially if they were done outside Alberta, aren't really available to us in Netcare, so they're hard to get. But if you have them and they come with them with their charts from somewhere else, it's really important to send those along. The next thing we want to know, is this patient currently flaring? So people might just say, I know this person is Crohn's, they've moved here from Red Deer, could you see them? If they're well, our urgency to see them is a lot different than if they're flaring. So if they're flaring, we want to know how many bowel movements a day. Just like Dr. Dielman said, if you're having 20 bloody bowel movements a day, you're a lot more sick usually than if you're having 5. Blood is always a worrisome feature. If they're losing weight, and then always important, if anyone with diarrhea, if you can send the stools off before they come to see us, so we make sure we're not trying to treat infection with immunosuppression. It's always a good thing. And last thing, in terms of blood work, we don't need you to do every blood test known to man, but there's a few things that are helpful for us in terms of triaging and deciding how urgently to see somebody. So a CBC is important to see if they're anemic or inflamed. The CRP or other inflammatory markers are important, and then iron studies. So that's probably the minimum that we'd need. Albumin is helpful, B12 is helpful, electrolytes and creatinine, and also liver enzymes. So all those things can be helpful, but if you have the top 3 things to send to us, I think we'd all be able to determine how urgently we need to see the patient. And the last thing to remember is that we have busy practices, and all referrals are triaged by urgency. So if somebody is sick, we see them right away. So Monday, I'm on consult, somebody called me, 6 months of bloody diarrhea, hemoglobin of 95. I saw her today and diagnosed her with left-sided ulcerative colitis. And so we can see people relatively quickly, but we need to know that they're actually sick, because otherwise somebody could come several months down the road and it wouldn't affect their medical care, and we want to be able to have the space to fit those more sick people in.
Well, thank you, Dr. Croker and Dr. Dielman. We've gone through a lot for you today. We're going to leave this information for referral up, because this is a critical piece of information that we want to share with you today. And let's go through a few questions in the remaining 10 minutes.
Can we mention that top thing?
So it's important, we are seeking CME credit through the College of Family Physicians. We don't have that accreditation yet, and so this will have to certainly now just serve as a personal learning project for you, but we'll acknowledge when we do get that CME credit. First question, maybe I'll give Dr. Dielman a chance to talk for a second. Patient who has recurrent fissures, should we do any further testing?
Well, recurrent fissures is not always a hallmark of IBD, so that's I think the recurrent, what you could do is, what are we talking about? Is this really a fissure, or is it maybe the beginning of a fistula? So some people can say, well, you could do a colonoscopy, at the very least, to do a sigmoidoscopy, then you can have a good overview of that fissure.
But I'm a family practitioner. I can't do gastroscopy, colonoscopy. So what should I do?
So the first line treatment for recurrent fissure is typically in patients that have, for instance, hard stools. It hurts a lot, and I always emphasize to whenever I see these patients for anal hygiene. It's really important for fissures that to be kept very clean, that whole area, and to tell the patient, for instance, to wipe after every bowel movement, to let this thing heal up, and then you can use some creams, and that will also help the fissure.
So should this person be looked at for IBD?
Not necessarily.
Well, you should do exactly what we said. We should take your symptoms, do your blood work, and look for other signs. Yeah. And because I think often, a fissure alone is not enough, but if you have other stuff going on, family history, all sorts of things.
Something else. That's right.
Absolutely.
Yeah.
So let's go on to the next question. Maybe I'll take this one since I haven't had a chance to do a question.
I haven't had a question since I've arrived.
My patient keeps coming back with GI symptoms, abdominal pain, cramps, diarrhea, weight loss, and iron deficiency. She has seen a gastroenterologist, and both gastroscopy, colonoscopy, and CT scan were normal. What else should I be looking for? So this person, particularly if they're in that age group of 15 to 25, has Crohn's disease that hasn't been picked up yet. One of the important things I think to note is that the regular CT scan is not sufficient. We have introduced into Alberta a new test that's called CT enterography, which is a test that delivers an oral contrast that dilates the bowel slightly and allows the radiologist to measure the thickness of the bowel wall, which is how you make that diagnosis of inflammation, the thickened bowel wall. The standard CT scan is not sensitive enough to pick that up. So I would think that this person probably needs, at some point in time, a reinvestigation.
Because of the weight loss, mostly?
I think the weight loss and iron deficiency, unless this is a female with heavy menses.
And you've ruled out celiac disease.
It's a problem. Okay. So, Dr. Croker, as IBD specialists, what's the best test for making a diagnosis? And let's assume that the physician who's asking this question doesn't have access to endoscopy in their office. So, what's the best test?
So the best test,
we've got barium enemas, we've got small bowel follow-throughs, we've got upper GI series, we've got CTs and MRs, so which ones do you want?
It depends a little bit about their symptoms again. So once again...
Pain, cramps, diarrhea, and bleeding.
No perianal disease?
Nope.
So without perianal disease, I wouldn't do an MRI of their pelvis, but if they do, I would do an MRI of their pelvis.
Okay, and which other tests are you going to use?
So the best test for radiology is only for imaging the small bowel, and I would do a CT enterography or an MR enterography. And so when I decide which one to use, I think a CT enterography continues to give better pictures because the images are acquired a little more quickly. And so, however, in young patients, I think it's reasonable to start with an MR enterography, or especially if somebody's already been to emergency and had a CT. So that patient you were talking about, I'd probably get an MR enterography rather than a CT, especially if they're under.
Do you have an age cutoff, Dr. Croker, for a CT?
Younger than me? No, just joking.
A real age cutoff.
A real age cutoff. Probably under 30 is when I actually would consider using an MR over a CT. Under like 25, more so, but I think it's like the younger they are. So as soon as if you're a pediatric, they would almost never order a CT scan, but so the minute you turn 18, you shouldn't just all of a sudden be ordering CT scans. You should really consider.
MRs are harder to get. So if you have someone who's 25, would you, and you didn't have access to an MR, would you easily use a CT?
If they hadn't had a recent one, yes. So I think one CT scan is not going to be the end of the world, but I agree. And we're actually working with the radiologist a little bit about decreasing the amount of radiation exposure. Right. But a standard CT enterography has a fair amount of radiation, and so that's why the MR is a better test. And I want to talk a little bit about small bowel follow-throughs and things like that, because you asked about it. So usually we don't order a lot of upper GI or small bowel follow-throughs anymore. For upper GI, we can usually assess that with endoscopy, and for colons, we usually can do that. So we almost never order a barium enema for assessing inflammatory bowel disease.
But I think it's important to tell the family doctors that for inflammatory bowel disease, the sensitivity for small bowel follow-through is 23%, and for CT enterography, it's near 80%. So we should not be doing small bowel follow-throughs any longer for looking for inflammatory bowel disease.
I think if you...
We should remove that from our...
Well, I think you have to think if that's all you have access to, it can help diagnose strictures, but in terms of others, more subtle disease, it's actually probably not so helpful. And so you have to really think twice before ordering, because I think a CT actually probably has about 2 to 3 times the radiation of a small bowel follow-through, so you do have to consider that. But I agree, it's not a great test for anything we use. Barium enemas, I've never ordered a barium enema for a patient with inflammatory bowel disease. I know that it's easier to get access to them than sometimes with colonoscopy, but they're not very sensitive for small lesions. They're actually the best for picking up things like polyps or cancers, and that's not usually what we're thinking about when somebody presents with pain, cramps, and diarrhea.
So this is a question for Dr. Croker, since she's an expert in this area. The question is, my patient has ileal disease and a strong family history of TB. 30 seconds, Dr. Croker, how can you differentiate between them?
History, TB tests, biopsy. That's pretty much it. Because it's actually hard to distinguish in the grand scheme. If you've had exposure to TB, you have a very high likelihood of having TB, even though TB of your bowel is relatively uncommon. But you have to consider it. And so especially since some of the treatments we give, like the anti-TNFs, can actually make TB worse, then we have to be really careful and distinguish them.
Biopsy is important. Again, CT scan, looking for large lymph nodes in the mesentery, that's important. And it's a complex diagnosis to make. The last question I'll take is, what about video capsule endoscopy? So that's a relatively new test we have here in Alberta, probably over the last decade. It's a small little capsule that takes 72,000 pictures and a little video as it passes through your intestine. There's 2 centers that do it, Edmonton and Calgary do that test. It needs a referral, and the patients prior to having that have to have had a CT enterography, gastroscopy, and colonoscopy. And if you want more information about that, we'd be happy to provide that. And if you go to our website, we also have information on video capsule endoscopy. So, Dr. Dielman, Dr. Croker, we've used up our hour of time. I wanted to thank our audience, the physicians that have dialed in, all of the patients that have dialed in. Thank you for attending today, and we look forward to seeing you again next month in our IBD Care webcasting. Thank you, and good night.